So we are going to present today a large initiative that we took about 6-7 months ago, which was implemented at Mayo Clinic. It is the multidisciplinary staffing in the Mayo Clinic emergency department. And with me, my colleague from emergency medicine, Mayo Clinic, David Nessler. So we'll co-present the presentation. So the plan for today's presentation is first, David is going to talk about the unique aspects of ED staffing and why it's a challenging task. And then we are going to describe you our methodology, which is a volume-based shift design. And we will also describe in detail how we coordinated multiple shifts among multiple roles in the emergency department. And finally, we are going to show you comparisons of various important performance metrics pre-implementation and post-implementation based on this work.
So yes, thank you. I'm Dr. David Nessler. I'm one of the emergency medicine doctors, otherwise known as an ER doc at Mayo Clinic in Rochester. So Mayo Clinic currently is the #1 rated hospital by U.S. News and World Report. We're very honored to have that ranking. And it's an enterprise consisting of several hospitals throughout the country, but the main campus is in the very south of Minnesota called Rochester. It's the largest, in Rochester is the largest private hospital in the country. It's got 2,000 beds, it's massive. And we have a very large emergency department as well. Traditionally across the country, emergency departments that see, say, over 60,000 patients a year are considered high-volume emergency departments. And we see 73,000 patients a year through the department. So we're a high-volume, level 1 trauma center, stroke center, STEMI receiving center, magnet hospital, all of the things that go with ERs to understand that it's a high-level acute tertiary care hospital. Staffing in ERs has traditionally been very complicated. Frankly, there's many articles discussing how staffing and scheduling for a 24/7 practice is done off the cuff. There's very little in the way of analytics or understanding, and this is because of a fairly simple thing if you think about it. ERs mean a lot of things to a lot of people. If somebody you know was involved in a major car accident, life-threatening, for example, that's what you'll think of. Other people think of the place where you go when your 1-year-old has a fever, if you twist your ankle, you name it, or if you're in septic shock. That's why you go there. So the people that we see have very different service times. It's one of the only unplanned services in healthcare. I can assure you other aspects of healthcare may seem unplanned, but they are. There's a federal law in 1996 that says that an ER has to see anybody who's asking for help, period. So because of that, there is no way to turn away anybody, no matter how busy you are. The acuity can vary widely. It's from birth to grave, and you never close. We haven't closed since we opened in 1984. So when it comes to staffing and scheduling, nobody's really sure how to do this nationally. The standard is to put bodies where bodies are, and we're going to start going through this. But this project was undertaken at the same time that we were redesigning. We're going to go into this in a minute, but volumes and acuities are going up over time. The RAND Corporation just put out a paper about 1.5 years ago explaining how ERs have very steadily, the workload, the acuity, and the demand is going up over time. We can expect that has to do with an aging population, reimbursement changes, the fact that the number of emergency departments has shrunk nationally. And so we can just assume that each year the workload grows and the acuity grows. I could go on, but there's plenty of science since basically going back 15 years that this is a steady increase. And so now we had just redesigned our physical plant to help increase our capacity. We were told at the same time, due to healthcare reimbursement changes, that we had to be FTE neutral, meaning who you have is who you have. And with all of that, our chair wanted to send a video message as part of this, and so we're going to show this video here in a moment. And
so in this video, Dr. Eni Sadasti will describe what was the charge that she put on the multidisciplinary team she put together to tackle the staffing issues that we were having in the emergency medicine. So we are going to listen to her. Oops.
Hi, my name is Annie Sadasti. I'm the chair of the Department of Emergency Medicine at Mayo Clinic in Minnesota. Our emergency department in Rochester, Minnesota is a level 1 trauma center. It's busy. We see 75,000 patients per year in an emergency department that is approximately 1.25 acres. The landscape of our specialty has been changing vastly. Our volumes can be oppressive. Our patient complexity has been rising. And unfortunately, wait times have been increasing. This is a big problem for the specialty of emergency medicine. And as a leader, it's a big challenge for me. So I asked a really talented group of people, physicians, operations researchers, residents, nurses, other allied health staff, to really look hard at this problem, to create a new staffing template that would be patient-centered, that it would reduce wait times, and solve the challenge of the waiting patient. Because there's danger with every patient that waits. I asked the group to do the following. 1, to create a patient-centered schedule. Not one that works for our schedules, but one that's best for patient care. 2, that would improve operational performance. 3, that would coordinate across disciplines so that the physician schedule and the nursing schedule and the resident schedule and the other allied health members of the team were scheduled with intention so that we were all there at the right time to serve our patients. That this new schedule would be data-driven, not one of these situations where we think this is the best schedule, but rather it was intentionally designed to match and model for patient arrivals, volume, acuity, to put our people where we needed them and when we needed them. And finally, as every good leader should do, I provided a deadline, and I asked that the new schedule be FTE neutral. Now, that was no small feat. FTE neutrality in the face of rising volumes and rising acuity was almost an impossible ask. But I did it, and the team delivered.
Okay, so you want to take this one too? So basically, we had a very, very small amount of time to deliver this project. So, and that's kind of the deadline that Dr. Sadasti was talking about. And then almost every analysis that we did, and I'm going to share some of it towards the end of the presentation, showed increasing volumes. And then also the case was that we couldn't hire anybody. No increase in nursing staff, no increase in physician staff, no one. So we had to do whatever we have, and then we had to actually kind of make things better somehow, magically. So, and again, this is a graph that actually Dave Nestor, on the first day we met, drew. He said, this is kind of what we have today. So the workload per staff member goes down, and then people feel really idle, and then all of a sudden they feel extremely busy. And that's kind of that's the sense that I got from speaking to almost every staff member in the emergency. That's how they feel throughout their shift. And again, they basically said that this is what we need to kind of convert this picture to that throughout the shift, just we have the right amount of workload that doesn't like swing like that. So, and this to me was kind of how I started kind of developing the idea of volume-based shift design, and we are going to talk about that in a minute. So the first thing we did is we started looking at some of the trends. And what you are seeing here, we are going to actually show similar graphs. So I'm going to take a minute to describe how this graph is organized. Every panel is a day in a week. And every dot that you see, every blue dot is a observation that we have in terms of number of patients in the entire ED in the past 2-3 years at Mayo Clinic. So every dot basically represents, at that time interval, I observed a certain number of patients, okay? And the line is basically the median line. And you can kind of see that, there are strong patterns in terms of how our volume changes. But then there are significant differences from one day to another. For example, our Mondays are significantly busier compared to other days. And then there are kind of differences in terms of when that peak really occurs in terms of patient volume, okay? So we started thinking about, okay, so we have a couple of months ahead of us to be able to deliver this giant project. We started thinking about, as a team, what are the practical approaches that can guide ED staffing. So the first thing that comes to mind is, of course, queuing theory, and there is some literature on queuing theory and its application to ED staffing. It's great because it addresses the time-varying aspects of patient arrival rates. But most of the time, the methods developed using queuing theory relies on the assumption that service is a one-time encounter of a random duration. But the issue is that the ED clinicians actually rely on a sequence of diagnostic tests, laboratory tests, to be able to diagnose what's going on with the patient. So it's not like they are busy with the patient in the entirety of their stay. They come and check on the patient and then order some tests, go back to another patient, and while these tests are being organized. So therefore, we felt that, queuing is a good approach, but maybe we may not have all the granular timestamp data to be able to really construct a realistic queuing model. And another aspect of queuing is that it assumes that service times are assumed to be independent of system state, which kind of ignores the human factors aspect of it. That, depending on the business of the ED, things actually get slow down in terms of how you respond to the patient demand. So therefore, we kind of wanted a more practical approach, which is more based on volumes. And there are several reasons why we wanted to use a volume-based approach. First of all, that's the current state of practice at Mayo, and I'm going to show you some pictures how they actually organize their shifts based on volume. It's very easy to interpret, and it's kind of close to how clinicians think about how they manage their patients. So they actually kind of think about, okay, I'm managing 10 patients right now. And then they kind of go from one patient to another. And again, when you actually display your methodology in terms of patient volume, it makes sense to them. So, and again, we are really talking about staffing, and it's really a very touchy issue. So you really need to be able to explain your methodology to clinicians, nurses, residents, etc. So, go ahead.
To jump in, I also wanted to add, you've probably heard of some queuing theory discussions in emergency department management in the literature. Those are traditionally done at what we consider to there's something to realize nationally. The average ER sees 50% low acuity patients. So half the patients are low acuity, half are medium, and the other half is composed of medium and high acuity. That is the state, and particularly that is the state in, say, county hospitals and other academic centers that you will see. Of course, that's not true for everyone, but there was a benchmarking group that was looking at different acuity mixes, and we did find out that at our institution, our particular institution, for a high volume ED, we have the highest acuity mix in the country. So I bring that up only in that I think the queuing theory model, as Dr. Sir was explaining, can be very helpful when the service times can be more predictable. Lower acuity patients have more predictable service times. Higher acuity patients have, there's less predictability just because of the decreased ability to have the patient wait. So that's important if you're thinking about other published literature on queuing theory and why that doesn't always apply to every center. Our thought was if we could make it apply in a high acuity setting, then it certainly would apply in the lower acuity setting, but the vice versa is not the case. So
we set on, okay, so we are going to develop a volume-based approach. So we are going to actually base our shift design based on the volume, historical volume data. So that's where the data-driven aspect comes into picture. But the issue with volume-based approaches is that the volumes are actually a result of the existing staffing levels. So if you basically have a lot of operational inefficiencies, that you have a systematic understaffing at certain hours of the day and systematic overstaffing at other times, then they reflect on the volume data. So then if you actually build your optimization model on the volume data, then you are basically running the risk of propagating all those inefficiencies in your new design. So you are pretty much replicating your errors, right? So, and again, to kind of show this, this is kind of the historical data from Mayo Clinic. The gray shades kind of represents the capacity or staffing levels of the ED back then. And then the blue line is the median patient volume, and the red line is the hourly arrival rate. You can kind of see that that's kind of how the ED optimized, Mayo ED optimized their shifts. They basically were putting the shifts wherever they saw the highest volume peaks, right? But you can kind of see that the arrival times or arrival rates kind of make a peak around noon time, even though you basically have the volume peak around evening hours. There's a huge time lag, right? And then based on our analysis, it kind of shows that there is this, significant accumulation effect because you don't have enough staffing levels. If you go to the next one. So this is, again, I hate to show two different y-axes here, but the blue one is the physician level shown on that axis and the mean arrival rate on this axis. You can kind of see that patients are kind of arriving at a faster rate very early on in the day, but we don't have enough staffing levels, and then therefore they keep waiting and waiting and waiting until you basically have this huge accumulation effect at hand. And that's how the physicians, the care team basically felt that they were most busy at evening hours, okay? So as we were discussing, okay, so we are going to come up with a volume-based method. Volume basically have all these inefficiencies already incorporated in it. How can we somehow purify all those operational inefficiencies that exist in the volume data so that we can come up with the so-called ideal patient volume? So you can kind of think of this, okay, I'm going to, if those who are familiar with like radiation therapy work, you start with a, ideal dose targets that you want to actually hit your tumor, and then you construct your treatment plan. So the idea is kind of similar. So you want to come up with an ideal volume, the one that reflects when you have optimal staffing levels throughout the week, what would be the volume curve that you would observe. Then you actually kind of use that as to reverse engineer what your staffing levels should be. So that's the approach that we took. So to be able to do this, again, this came from our clinician colleagues, Dr. Nestor and Dr. Helmick, that they said something about staffing levels, patient to staffing ratios, that really affects the length of stay of the patient. So somehow if we can construct what would be an ideal length of stay for different patient populations, then maybe we can add that ideal length of stay to historical arrival data to construct an ideal patient volume curve. And that was, to me, kind of start of everything. So again, most of the time as operation researchers, we think we know how to do it, but then until we listen, we really don't know. And then most of these key ideas really came from our clinician colleagues. And then we simply kind of put the mathematical rigor around it, basically. So before I explain to you how we did calculate the ideal length of stay, let me actually tell you the kind kind of a very simple view of patient's stay. And maybe you would be much better.
So we understand that any patient is going to have these discrete time issues. They arrive, when do they get to the bed? When do they get their first workup initiated? There's going to be results received. Different people, based on their conditions, may have multiple stages. And then there is this disposition decision, and then, of course, they leave. The fact is that every single person, roughly what we can say in our shop is that 30% of people are admitted, 70% of the people go home, and each one of them will have this varying length, largely because it depends on how many stages they have in their workup. Is it a single stage, double stage, triple stage? And so it's hard to tell, again, because that's why you get this difference in length. So what we have here is just various ways of explaining that they can have the different time periods in the patient's length of stay require more input from staff than others. And so we're trying to model out for a population of a varied set of patients, where is the time that the providers and the nurses, for example, need to dedicate to the patient stay. And of course, there is waiting in middle of that. If you are getting a CAT scan of your abdomen, that you order it, then things happen, frankly. Other people work on this for a while, and then results come back. So you want to try to have the workload stacked in such a way that you can move from patient to patient, because managing patients simultaneously is what we do.
Right. So given that, so we wanted to understand all those factors, both in terms of patient characteristics as well as system level influences that affects length of stay. And this graph basically shows that some of our patients, unfortunately, have a extremely long length of stay. So we wanted to understand, can we control specific patient characteristics and then somehow figure out the actual staffing level influence on the length of stay? So to be able to do that, we came up with, we used a classification and regression approach, in which, and you can kind of think of this as a regression model. So where length of stay is our response variable, that's the thing that we are trying to predict. And then we came up with several variables that seems to be affecting length of stay, some of which are system level variables. These are the variables that are related to our staffing levels. Number of patients per, for example, nurse during the length of stay of an individual patient. So we calculated these variables for each individual patient to capture kind of the experience that they had when they were staying in the ED. But then some of the other variables were related to the patient characteristics, related to complexity of the patient, severity of the patient, age of the patient, etc. So we kind of put all of these into one model, and as a result, we got a tree like this. So, and again, I'm only showing the CART analysis for adult patients. And the way it works is it splits the patient population into subgroups. It picks the variable that seems to be most influential on the length of stay. And then it also determines the level at which it should split the population using that variable. Okay? And again, as you see, the first variable that came up that's most influential in terms of length of stay is ED level, which is a measure of complexity in terms of how complex these patients are. But the very next variable was maximum number of patients per provider. And interestingly, again, we don't pick the threshold. The algorithm picks the threshold. The 7.5 was universally the threshold that it picked. And whenever the maximum number of patients per provider is above 7.5, the average length of stay seemed to increase more than an hour. Okay? So, and again, to look at it on a different graph, so these two distribution actually shows those two patient populations. In terms of complexity, they are both adult patients, and they are low complexity patients and high complexity patients. But the only difference is that one group of patients experience a really busy ED, the other group of patients experience not so busy ED, and it really affected their length of stay. And this is really contrary to the notion that a physician should be able to manage 11 patients at a time. But then our numbers suggest that it's much less than 11. So to be able to construct this ideal length of stay, we basically came up with a very, very simple procedure. So we have this two separate distribution from which we can come up with empirical CDFs. And for those patients who experience busy ED, we simply kind of project that length of stay onto the other distribution to calculate what would have been their ideal length of stay if this patient actually experienced an ED where the patient to staff ratio was less than 7.5. And one more. And this way we calculate the adjusted length of stay or ideal length of stay for each patient, and then process our historical arrival data to come up with an ideal volume. To kind of compare what difference between historical patient volume and ideal patient volume, we kind of constructed both of them. So this is the historical patient volume. And if you go to the next slide, this is the ideal patient volume. The moment, the difference between them, you can kind of see that ideal patient volume, as expected, is lower than the historical patient volume. And it's shifted towards left. Remember that there was a time gap between arrivals and the peak times. Now the ideal volume is kind of shifting and getting closer to the arrival rate, okay? And this gave us a very simple optimization model to optimize. So the main parameter is the ideal patient volume and the thresholds that we got from the CART analysis to determine ED capacity. A set of admissible shifts, a set of pods, and then, of course, our budget constraint. These decisions are which shifts to cover which treatment area or pod, when a pod should be open, and where should we have a pediatric coverage. The minimization was we wanted to minimize the difference between our ideal volume and capacity, and we really wanted to make sure that we meet the ideal conditions throughout the week. And there were a lot of constraints related to how pods should be open and closed, what type of constraints we should have to regulate pediatric patient coverage, etc. The results were we basically moved some of the shifts way early, actually 3 hours early, and this was extremely controversial, and a lot of physicians and nurses basically really objected to this because they felt that you are really moving the people that at the really peak hours early on. And it was crazy to them.
And that was much of what we did. And there's, as you can see in these models, it varies day to day. We want to, with respect to time, we want to be able to open up for questions here in a few minutes. But the real issue was we were taking these shifts and moving them over. The blue is putting staff where staff previously didn't exist.
It's red.
Pardon me?
Red is where we put new
There we
staff.
go. I'm reading this wrong. You're right. I'm sorry. The red is where we put, I'm colorblind, so I probably shouldn't navigate the colors. But the concept is we turned the shifts around during the peak times, moved them earlier. There was a lot of concern over safety because as we all know, there's less patients at 3 in the morning than there are at 3 in the afternoon. There's less staff at 3 in the morning than there are at 3 in the afternoon. If you take staff and move them earlier, try to predict and cross your fingers that you don't leave vulnerability later in the night. This was a big issue, so we had to make sure to sell this but convince our staff. And also to align 180 nurses, 43 attending physicians, 24 residents, and 18 operations clerks to all do this is what we did. We have various models to explain how these looked.
Right, so because I don't have a lot of time, so I'm going to go through. So the physician shifts were our central kind of model. Then we built everything else on top of it. So we organized RN shifts using a very, very similar method, using the ideal volume and optimizing nursing shifts, physician assistant shifts and resident shifts around this. So at the end, we got this master template. So every role is coded with a letter here, and each letter basically represents different type of nurse, different type of resident, different type of physician, etc. And then each column actually represents a treatment area in the ED. So this is the staffing template that Dr. Sadasti was mentioning. And one interesting thing about nursing is nursing has several kind of different shift types. And the way that they actually organize their shifts were, one type of nurse would be staffed exactly the same way every day of the week. So because there are so many different combinations that you can do, so our optimization basically kind of mix them so that we can really shape the staffing levels according to that ideal volume curve. And then the result is that now we know which nurse should work where at what time and how many of them should cover different treatment areas. So I am going to actually take 2 more minutes from the questions to describe the comparisons. So we had 3 time periods to look at. So I'm going to show you 2 time periods, pre-implementation, the same 6 months, December to May, 2013 to 2014, 2014 to 2015, and the same 6 months after implementation. Before I show you the results and compare different performance metrics, I want to actually show you what the patient volume trends look like. So from these 3 periods, you can see that the patient volume has been increasing about 5% every year. So basically, compared to the first period, we had about 11% increase. But it's not just the count of patients. The complexity of the patients are also increasing because Mayo is attracting a lot of high complexity patients all around the world. And our complexity, measured by this ED level 5, has been increasing. So 13% from this year to this year, 20% from this year to that year. Okay? So, and again, not just the complexity, the severity of the patients are also increasing. Severity and complexity are 2 different things. Severe patients are the ones that you really respond quickly, like those trauma patients, but they may not be really complex patients because you know what to do. But again, the severity has also increased because severe patients really draw a lot of resources. And then you can see that we had 31% increase in our ESI 1 and 2 level patients. So given these increases, I'm going to show you the results. And remember that staffing levels were exactly the same. We didn't really change anything in terms of number of people hired. So, and there are 3 main metrics to compare: door to bed, door to provider, and length of stay. So this is how quickly we are responding to the patient, and this is how quickly we are getting the patient out of the ED, right? So, and then these are box plots. The lines here are the medians, and you can kind of see that even though our volumes have increased significantly, we were able to kind of reduce door to bed, reduce to door to provider, and almost match length of stay with respect to 2 years ago. So, and I have 2 minutes of video of Dr. Sadasti talking about the results.
We skip the video.
We can skip it, maybe. Yeah.
So, in short, we know that the volume, the acuity, the complexity should have been going up. By redesigning the staff, we have very measurable metrics. Outcomes are always, frankly, it's a big challenge in national healthcare. It's hard to measure the outcomes of patients because you have to have very complicated risk-adjusted models, and if you can figure that out, the White House would love to hear about it. But in the meantime, we're definitely improving the service times, and I think at this point we'd like to open up for questions.